Good morning and welcome to this Adult Immunisation Forum. My name is Professor Robert Boy. I'll be chairing much of the meeting with some of my colleagues as well. It's great to be with you from Sydney. I would like, importantly, and first of all, to acknowledge the traditional custodians of the various lands on which we are partaking in this conference. And indeed to recognise the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respect to elders past and present, and I celebrate the diversity of our Indigenous people, their ongoing culture and connections to the lands and waters of Australia. My involvement in immunisation goes back over 30 years, and I'm pleased to be a former chair of the Immunisation Coalition, and I've been the director of the Immunisation Coalition for over 10 years. We've got a session coming up in just a couple of minutes on COVID. That's the focus at the moment, but the day will progress with sessions on modes of immunisation, other infectious diseases, and we've got a very full program. We're going right through until almost 6 p.m, evolving and new vaccines and new strategies. So it's a pretty exciting program. We're going to keep to time as best we can. So without further ado, I'd like to progress and introduce the first speaker. And I just don't know him very well. I've got to look up his bio. Sorry about that. Professor Robert Boy is an honorary professor of paediatrics and child health at the University of Sydney. I've said already he's a former chairperson of the Immunisation Coalition. And he's a former director of Australia's National Centre for Immunisation Research and Surveillance. He has a long history in infectious diseases, their treatment and prevention. So over to you, Robert. Can you now screen share? I'm very grateful to many of my colleagues for helping me with slides for this presentation, and also for help from industry, from Moderna in particular. These slides are all quite new and current, so any mistakes are mine, not anyone else's. And it's a delight to talk to you about the prevention of COVID-19 in children. It's a very topical issue and has been for the last year. I wrote an editorial for the MJA a year ago saying we need to tread carefully and know the epidemiology and the safety of disease and the safety of vaccine. A poll of the general public suggested late last year that they wanted 5 to 11-year-old children jabbed, but there was a lot of resistance in the general public to mandating vaccinations in children. Interestingly, this year, the JCVI, the Joint Committee on Vaccination and Immunisation in the UK, approved vaccination for 5 to 11-year-olds, but as a non-urgent, so that it could be done at the GP and not urgently as part of a school vaccine program. They did also emphasise the importance of high-risk children. As you know, high-risk children include those who have disabilities, major medical problems affecting the heart, the lungs, immunosuppression, and so on. They are the focus of vaccination programs due to start for under 5s in Australia quite soon. Now, one of the interesting and important points to consider whether you vaccinate children is whether the disease is severe enough to be worth preventing. We've heard all along that children get COVID much less seriously and often without symptoms. So does the epidemiology justify vaccination? Well, the epidemiology is evolving. Delta was bad in the sense of killing many people, being highly transmissible, but Omicron being so much more transmissible has led to even more deaths. So Omicron is on the wane, but what's coming next? Nothing? Another variant? There's sure to be something, but what it is, we just don't know. The US has recorded over 1 million deaths from COVID in their population, almost all in elderly people. Less than 1,000 have been in children, teenagers, and also infants. So far, only 1 in 4 US children have been brought by their parents for vaccination against COVID, but over 1 in 2 adolescents are fully vaccinated. In Florida, their Surgeon General said children need not be immunized, which the White House press secretary found deeply disturbing. So there is some polarization in the public and in politics. In February, I've said already, the JCVI said it was non-urgent to vaccinate children. And finally, the vaccine will, however, prevent severe illness and death, and may go on doing so in children with stronger immunity and better memory for years. So before you protect children, we're already routinely protecting adults and have been for over 18 months. I thought I'd bring your attention to this study of pregnant women. If you, in looking at my slides, focus most often on the material in bold, so you don't have to read it all, the effectiveness of maternal vaccination against hospitalization for COVID turned out in this study to be about 50%. But it was 80% during Delta and about 40% during Omicron. So that shows you how Omicron has mutated, especially at the receptor binding domain on the spike protein, and about how it's more transmissible. So what about the latest figures from Australia from August this month? Well, interestingly, this year we've observed almost all of the 14 deaths have been this year in children under 10 years, including more than half of them in children under 5. Some of them may have died with COVID rather than of COVID, and that is still being sorted out. A Nature Medicine paper from the UK demonstrated that deaths, about a half or a bit over a half, die of COVID, and over a half of children who die have got a predisposing medical problem. Going down to my third point, COVID-19 is set to be the third leading cause of death in Australia this year, based on projections and analysis of real data. So the issue of death from COVID is a real one. We've got a double truth. Some people get severe disease and die, and many people get much milder disease and are not even hospitalized. But by the end of 2021, we'd had over 2,200 deaths in Australia, but the rate of dying was 10 times higher in the UK and the US. Perhaps a salute to Australia's political and public health systems, as well as the public themselves observing social distancing and getting vaccinated. And if you look at excess deaths, as Australia did not have excess deaths until the beginning of this year. You have to look at this bar right to the bottom where Australia does not have excess deaths in 2020, 2021. But subvariants of Omicron have changed that. We've had 3 waves this year of Omicron. And by June, the 2 months of June, July, we had more deaths in those 2 months than in the whole 2 years of 2021. Australian Bureau of Statistics said that over 5,000 more deaths occurred in January and February alone compared with what would have been expected. So what's happened, is Omicron more severe? Well, it's definitely more transmissible. And if we look at the basic reproductive number, we went from the Wuhan ancestral strain being reproductive, 1 case in a susceptible population causing on average 2.5 cases, to more than 10. And Omicron BA1 and 2 were bad enough, but BA5 is more like 18. So we know as of March that the widespread transmission of Omicron globally meant that continued evolution was likely. If millions of people are infected, someone may well in their body have a virus mutate to a yet more transmissible form. So figures for a paper just published a week ago from the National Centre looked at Delta disease in children at the end of last year, the second half of last year. And the main measures were frequency of disease, hospital visits, and other severe outcomes. So just going again to the bold, if you had another major medical condition, your likelihood of hospitalization was more than 7 times higher. And it was chronic respiratory disease especially, but also heart disease. And curiously, people with asthma had a lower risk. So the likelihood of admission for medical reasons was highest in infancy, declined in primary school years, and went up again in the high school years. Most Delta infections in children were, however, asymptomatic or mild. More children were hospitalized for social reasons than for medical reasons. So this is Australia for the last 6 months or so, 7 months, the outbreaks we've seen. And if you note that 0 to 4-year-olds, the rate of confirmed infection has been lowest in them and highest in 12 to 17-year-olds. But here's the disturbing thing. Just this year, in under 5s, we've had 9 deaths. And that is almost certainly Omicron related. Some of them may have died with rather than of. In terms of other severe complications, pediatric inflammatory multi-system disorder has been tracked very nicely through the PEDS network, Pediatric Active Enhanced Disease Surveillance, and over 100 children have been reported. And this year alone, about 90, 1 in every 2,000 children infected with COVID. If we look at age-specific mortality on a global scale, we see again that children are especially affected. ICU admission is also much more common in children under 1 than in older children. So many people, pediatricians, including myself, have said this is a generation-defining disruption, a major problem for children. And the indirect impacts of COVID may well have been worse than the direct infection sequelae. A pediatrician from Melbourne, Professor Goldfield, noted that online learning, social distancing, increased screen time, reduced access to healthcare, less community support, all have repercussions. And Nick Wood on the last line, effort is needed for resilience building in children. Goldfield also said that job loss and reduced income in parents is a risk factor for harsh parenting. Well, thankfully, we've got the highest employment rate now suddenly, so that's one silver lining. Future job prospects of children and even their lifespan are influenced by their education level. The more education you have, the longer you live. Here's some data from the US looking at 3 million children under 17 years of age, comparing COVID cases with controls and finding that the major but rare complications of embolism and myocarditis were 2 times higher in children who'd had SARS-CoV. If you had, and that was a much more likely occurrence, especially the myocarditis, than after vaccination. Some studies coming out in the last 2 months suggest that COVID may be worse the second time round. Most cases aren't, but there are studies pointing to the fact that a second infection can have major complications. So looking at the bold, compared to people with the first infection, reinfection contributes additional risks, all-cause mortality, hospitalization, and other adverse health outcomes, heart and lungs, etc. A paper last month in JAMA looked at antibody levels after disease and suggested that they rise much higher in children but they fall faster in children too. So they, at 1 to 4 months, children had an antibody level, if they were under 3, of about 350, whereas it was in adults aged 18 above 64, five times lower. At 10 months, it had about halved in all age groups. And so although it rose faster and fell quicker, it did so in a way that we are familiar with, and that is half-life, a halving every few months or so. So although it fell faster, it was because it started at a higher level. All groups had a halving. Children's relatively high antibody levels produced by disease and vaccination does offer protection against reinfection, and it's suggested by this paper for at least a year. And the emergence of new variants, however, could completely change the ball game. The antibodies shown in children had higher levels of cross-reactivity to the various variants we've seen so far, so that's good news. A study from Qatar published in June analysed the Omicron wave early this year and looked at more than 100,000 infected people in Qatar. And it showed that full vaccination, 2 doses plus a booster, together with some natural immunity due to a mild breakthrough infection by an earlier variant, was associated with the strongest protection from Omicron. So that's what we call hybrid immunity. The study found that both vaccination and prior infection on their own provided strong and durable protection from severe or fatal COVID during the Omicron wave. So that was reassuring. Prior vaccination infection doesn't stop you from getting infected, it stops you from getting severe disease. One of the complications we're worried about in children from COVID especially is myocarditis, but it can also occur up to 1 in 10,000 times in teenage boys after their second dose of an mRNA vaccine. And these side effects, these symptoms in 1 in 10,000 or fewer boys are most common after the second dose and most common in older teenagers and early 20s. And they occur within 2 or 3 days of vaccination, and they settle very fast. Take-home message is that examination in Melbourne of 33 cases, published only as a letter in the MJA last week, the cases are mild and resolve. So they tend to only need symptomatic relief with anti-inflammatories like non-steroidals. So the Australian Vaccine Safety Unit, developed by the National Centre and Alan Lieb in Perth, has found that after we started vaccination in 5 to 11-year-olds with the Pfizer vaccine, that safety has been really the feature of vaccination in children. Indeed, even local side effects are less common in children than they are in teenagers and adults. The most common side effects are local, but systemic side effects can also occur, like fever and fatigue. But in the last line, the Australian data analysed so far are extremely reassuring, according to Nick Wood from the National Centre for Immunisation Research. I want to talk briefly about vaccination in children. The studies done by Moderna are a good example. You can see that studies have been done in primary school, preschool, and toddlers, and the numbers are listed in the slide. The summary of all that work is that the safety has been reassuring. The unsolicited adverse events within 28 days are very similar between vaccinees and controls, and the efficacy shows protection, but not as high as you might think. There's protection certainly against severe disease, but lesser protection against acquiring infection. So the local reactions you can see they are more common with the vaccine than in placebo, but they're mostly grade 1 or grade 2. the vaccine efficacy was around 40 to 50%, depending on whether you're over 2 or under 2 years of age. Why so low? Well, actually, I've said it already. Omicron is highly transmissible, and vaccination is based on the ancestral Wuhan strain, and so you get cross-reactive antibodies to the spike for Omicron. If you look actually at real-world evidence from California, Kaiser Permanente, we see that currently vaccinated adults have about 40% protection against infection. That's effectiveness. And so the data in children is very similar, the protection against Omicron, 40 to 50%. So we are inferring vaccine effectiveness based on immunogenicity, but we're collecting data to be sure in Australia that effectiveness is occurring and to watch for new variants. And boosters are under evaluation, protecting against BA1 and BA5. So ATAGI has said in Australia that we can vaccinate 5 to 11-year-olds with Pfizer or Moderna. And the Moderna dose is 25 micrograms, whereas Pfizer is only 10. What about children under 5 years? Well, we're about to start. 2 doses are required using the Moderna vaccine, except if the child has severe immunocompromise, when 3 doses are preferred and recommended. So the Moderna vaccine is the only one available very soon for children under 5. It's got a new formulation with a blue cap, 10 doses per vial. So watch out for that difference so you don't overdose children who you're vaccinating. Primary school children get 50 micrograms, half a mil. So now we have vaccine available for children under 5 and even down to 6 months of age. A year ago, I was totally against vaccination of children unless they had a high-risk condition. Now I'm moving towards favouring vaccination still for high risk, but potentially also for children at risk who attend daycare and preschool, where transmission is more likely. And the epidemiology needs always to be examined. And in my opinion, it's important that we continue to monitor this disease and the vaccine, as we've done so well in Australia, and that we vaccinate people to prevent severe disease. The next talk is by Professor Paul Griffin. Paul is well known to the Australian public for his expertise in infectious diseases. He's an adult physician and microbiologist based at the Mater Hospital in Brisbane. He's done an enormous amount of studies in many infectious diseases and on immunisation. Paul always gives a very wise and informed and up-to-the-minute talk, and he talks about big people, not little people like me. So I'd like to introduce Paul to speak on COVID vaccination in adults and a family approach. Thanks very much, Paul.
Thanks, Rob, and thanks to the organisers for the invitation to speak. It's a great meeting, so I feel very privileged to be a part of it. I'll just start off with some, my talk isn't, there we go, some disclosures. So I have been involved with a number of COVID vaccine studies and do some speaking and medical advisory board work. But at the bottom there, I just wanted to say, my role, of course, is as an adult physician, microbiologist, treating adults with COVID and running clinical trials of vaccines and therapies in adults and for adults. So Might seem a bit unusual that I'm being asked to talk about advocacy in families and children, but when we were discussing some of these topics, I'd just had my children vaccinated, and I think there was an appetite for me to maybe discuss some of the things that we went through in making those decisions and in trying to inform others. So I'll be, obviously following somebody who's got a lot more expertise in the paediatric space than I am. We just heard a great talk around some of the detail, but I'll be focusing, I guess, a bit more on my experience and some opinions around how that's played out. So what I'll go through is just some issues around supply and talk about some milestones, and then talk about uptake in adults, as well as with our boosters and our fourth dose winter booster, as well as in some vulnerable groups, and obviously a bit of a focus in children and some of my experiences. So we obviously had a lot of doses, and while there were some supply issues early on that maybe slowed down the initiation of our rollout, I personally think in hindsight, we did a tremendous job of securing a variety of different vaccines in a very large number of doses. And here's where we were late 2020. And I guess just to highlight how things can change, this is where we've ended up more recently, and you can see that adds up to over 250 million doses, including some there proposed as boosters, and that's about to come to fruition, hopefully in the coming months. But while supply was maybe a little bit of an issue early on, well, I think we did a tremendous job in securing ample doses for our population. And if we go through some milestones, so first case in Australia was 945 days ago. So in some ways, it feels like we've been doing this forever. In some ways, it feels like we're still just getting started. But 25th of January 2020 was when we experienced our first case. And we had vaccines approved to the day 1 year later. And AstraZeneca followed Pfizer being provisionally approved on the 16th of February. We then started to see, I guess, what we've become more accustomed to in terms of the first big variant arriving in Alpha at about the same time. And our rollout actually commenced on the 22nd of February. And you'll see there on the 21st that our Prime Minister, also known as our Minister of Health, Finance, Home Affairs, Treasury, Industry, Science, Energy and Resources, was actually dosed a day before the rollout commenced for everybody else. And then we started in a prioritised approach, frontline aged care first. We then expanded to elderly, vulnerable, other healthcare workers, and then the Indigenous. And then I think our commentary changed a lot around these vaccines. We had TTS. We had some early reports from other countries. We then changed our recommendations here. And as people in this audience, I'm sure will know well, that really did change our commentary around vaccines and safety, and was something that was a big challenge for all of us to have to deal with. We then had some recommendations for pregnancy not long thereafter, so in June, and then some further changes to the AstraZeneca recommendations shortly after that. We then had Delta mid-June last year, and we had again some changes around the intervals, for example, given we were in an outbreak setting. Children, remote vulnerable children, 12 and older, were recommended from the 2nd of August, and then all adolescents from 12 years of age recommended later that month. Pfizer 5 to 11s was approved, or commenced dosing, I should say, on January the 10th. And on the right is my 3 kids getting their first dose on that day. We then had Moderna be approved not long thereafter. We had some third dose recommendations change for the severely immunocompromised. And you can see that things were evolving both in terms of the new variants and the requirement for increased protection. And then Omicron, which people are probably a little bit sick of hearing about because I've heard so much recently, first reported in Australia 24th of November, in Australia 3 days later. And then this prompted, of course, a lot of changes to our recommendations, successive shortening of the booster interval, and a subsequent 4th or winter booster dose recommendation as well, which I'll touch on in a little bit more detail. And I think it's no question that we were very successful with our primary vaccination course, or our 2-dose rate. So overall, we achieved over 95%. You can see there's some subtle variability in different states, and there are 5 states or territories that haven't achieved 95% with the 2nd dose, but all were pretty close. So I think largely we'd agree that was a success. But our booster uptake, perhaps not quite so much. And if you look at some of these figures that are circled there, we've had just over 70% in the blue box on the top right of the eligible population. But if you look on some of those figures on the left, so just over 50% of eligible Indigenous population, aged care residents, 94. And if you look at the bottom, NDIS participants and residents, again, lower. And so they're some of our most vulnerable in our population and haven't achieved the same success with that booster booster dose. And if you look at the table on the right, we do see some very significant variability in the states. And my home state here in sunny Queensland has achieved just over 64%. So not really enough, I would think most of us would agree. And if you look at what happened with the eligibility, we can see successive shortening of the interval there. So a lot more people became eligible in a relatively rapid space of time, but our administration rate didn't really take off in the same way. And in many ways has actually plateaued subsequently. So I guess the gap between eligibility and people that have had those doses has, if anything, widened in more recent times. And if you look more recently at the fourth dose of the winter booster, and that's a terrible picture of me, but that's me getting my Novavax as my fourth dose. I was one of those people who became eligible with the first expansion of the eligibility at the end of May. So those people with significant medical conditions. So I had my Novavax then. And you can see that winter dose was first recommended on the 25th of March to those perhaps the most vulnerable and those that maybe had their previous vaccines the furthest in the past. That expansion in May and then a bigger expansion the 7th of July, recommended for everyone over 50, but also those in that 30 to 49-year age group can receive it. And I think the comment in the guidance there is the benefit is less certain. And we also had some changes in the interval from the first booster or infection to 3 months, whereas some of those have been at different intervals. And I think, to be honest, it's been a little bit complicated. And if you look at our fourth dose uptake here, 80% of eligible population aged care. If you look overall, 30 plus, 38.2. And if you look at those 65 and older, still only 71. So, while this is perhaps a recent addition, and so there's still time to try and work on that. Again, I think our uptake is not really where we need it to be. And, of course, there are hundreds of reasons, and there are people who are getting good quality data on this. These are some of my thoughts, but why has our booster rate plateaued so significantly? And I think, high rates of infection has led to a bit of a survivorship bias. Many people tell me they know lots of people have had COVID now and they weren't that sick, so we don't need to be protected. I think there is a lot of misunderstanding that people that have infection don't need a vaccine anymore, for example. And I think there's a lot of people also that see a lot of cases around. We had so much talk about how big these waves have been that they now are of the belief that the vaccines are ineffective. Otherwise, that wouldn't have been the case. And, of course, none of those things are right, but I think it is hard to overcome some of that. And I think there's a perception that the perception of risk has fallen. And we know in public health, for people to take action, they need a perception of sufficient risk. And if that perception of risk falls, people aren't going to want to do things. And so, we've had a lot of people talk about the reduced severity of Omicron, and I guess forgetting the fact that that's probably largely due to vaccination in terms of what we've seen with, low rates of mortality, for example, in this country. We've had a lot of reassuring messages when we've, appropriately rolled back a lot of our mitigations that we became so familiar with the past year or two. And I think the commentary around that has been that, we've been so successful. We've, in some ways, people have interpreted some of those discussions as we've won, we've beaten it, it's gone. And of course, that's not the case. And we've had a lot of other things to contend with in terms of the messaging. We've had natural disasters, global conflict, elections, etc. Also, fatigue and frustration. I think you've had a huge part of this. I mentioned the duration of the pandemic, and I think many people thought this was going to be a short-term thing. We've had a lot of changes in vaccine requirements, and again, many people have told me that, how can you know what you need to do when you've shifted the goalposts so much? And I guess not really taking on board the fact that it's the virus that's changed, and so our responses had to change accordingly. And then we've had different responses in different states, different recommendations in one state to another, which have made people question the legitimacy of the health advice when there seems to be some political imperatives there as well. And I think we obviously had a lot of campaigns to promote those first two doses. You couldn't go out to a pub, you couldn't travel, for example, without them. And then, of course, we couldn't do that. We shouldn't have done that, and we didn't with the subsequent doses, but it means the motivations are very different. And so that's going to have contributed as well. So what can we do to address that? And again, a lot of these are more opinion-based, some observations from me. But of course, we need a whole of system approach. We need to understand those barriers. There is a lot of variability by geographical region, but also socioeconomic status. So there's not a one-size-fits-all approach. We need to understand those challenges in those contexts and try and address them. And personally, I think communication is a big factor here. As I said, I outlined a lot of those issues there, and I think we need to have a way of explaining that caters to all those different groups and gets the right information to where it needs to be. I think we need to be cautious not to be judgmental. I mean, there's been a lot of people who have erred on the side of being judgmental when people didn't want to get a booster. And I think for, a lot of people, there is a bit of misinformation out there and people just want information. And I think that the bottom point plays into that a little bit, is that, we know our GPs are overwhelmed, our pharmacists are busy, they've done a tremendous job in this area, but they need time to be able to go through all this information, to be able to work out what those barriers are and to address them appropriately. And if they're not resourced to do that, then we miss that opportunity. And in terms of the Aboriginal and Torres Strait Islander peoples, we've obviously, I think, really missed the boat there as well. And you can see on the right, the 30 plus 4 doses is some 10% below the general population. And if you look at 3 doses, that's almost 20% below the general population. And these are a group that have their own inherent vulnerabilities as well. And so if anything, should be at least as high as the general population, I would have liked to see. And looking at that in another way, you can see that across the board in terms of geographical region, as well as different age groups, unfortunately, the Aboriginal and Torres Strait Islander peoples fall behind the general population in our country, which I think is a big issue. And so some ways that people have been dealing with that and trying to address that, which I think has been fantastic, is obviously trying to understand some unique barriers there. And I've been involved in a little bit of this. And, there is a difference in perception of risk in some areas, particularly due to geographical isolation. And maybe earlier on, when we were still looking at a lot of containment strategies, there are a lot of parts of our country that are very remote. And a lot of people there thought that the virus wouldn't come to them, which we knew was not going to be the case forever. There were some access issues, particularly in some of those most remote areas, and we need to make sure that we've addressed that adequately. There also needs to be specific messaging. Outreach programs, I think, were done and worked really well. The picture on the right is one of our Brisbane Lions stars, an Indigenous man from Mount Isa who travelled back out there and as a community leader, propagated some messaging around vaccination. But of course, we know that you need to work on the ground with community leaders and elders to make sure they have the information they need to be able to make the right decision and provide advice to the local community moving forward. And so I think a lot of this was done, but I think the figures would suggest maybe there's scope to still do some more in that space. And if we look at individuals with culturally and linguistically diverse backgrounds, it's a similar story. So if we look at that top right box that's been circled, we've got 1 dose, 2 dose, and 3 or more. General population is the top row, so 95, 95, 71. But if you look at people born overseas, it starts to drop off a little bit, and particularly people that speak a language other than English at home, there is a pretty significant gap there in terms of their booster uptake in particular. And again, I think there's a lot that can be done here. We need to identify the unique issues, and it's not just about language. There's literacy, health literacy, misinformation. It seems to be different misinformation in my experience to that might have circulated in other areas. And once again, we need a whole of system approach, local stakeholders, community, health service providers and health system in general, interpreters, appropriate resources. And I think we're a bit slow to get a lot of these off the ground. And people need to have competency and sensitivity around some of those specific cultural issues and a lot of community engagement. And just some examples that I've been involved with. We've had refugee health community engagement officers here in Queensland that I've done some work with. And you can see at the bottom there, it says there's a Refugee Health Network website. We have the COVID Health Engagement Project for the cold community. And here's some work I did with that group. And again, a terrible picture. I probably should have been more selective in some of these, but here's some talks that I did that were uploaded through some of their social channels and YouTube about different issues particular to that community. So I think there's some good efforts out there, but I think some of the gaps in uptake still highlight that we've got some more work to do in that space. And then in terms of children, and obviously I'm following on an excellent talk that's talked about this in greater detail, but I personally think that we still have some work to do here. This is a bit of a busy slide just to highlight that there is exceptional data on that children 5 to 11 years of age. We've got a great publication in the New England Journal of Medicine that demonstrated high levels of safety and efficacy, and the real world experience, in my opinion, has backed that up. So in terms of those approvals, we had vulnerable children 12 to 15, 2nd of August, all adolescents from 12, 27th of August. And we had that provisional determination by the TGA for the 5 to 11s, October 13. Pfizer approved in the US, end of October, and approved in Australia on the 10th of December, with administration commencing on the 10th of January, and Moderna followed shortly thereafter. And of course, we can't be dismissive of people's desire to want to understand the benefits and risks with this vaccine. We need to make sure that we have a discussion about both of those. And of course, there are a lot of things to consider. So, COVID is typically milder in children, but again, as we've heard well in the previous talk, that's not to say that some children can't get a more significant disease from this virus. But there's been a lot of talk about requirement for vaccination to attend school or sports. But we know that there are other approaches to making sure that can happen, and it's something that we need to be focused on moving forward. That we don't do that again in terms of interrupting children's ability to socialise and be educated, etc. Clinical trials showed the vaccine was very safe, and then there was a huge real-world experience that we had the ability to look at before utilising it in our country. I believe the number of children who received the vaccine in the first week alone in the US was approaching 1 million. So excellent uptake there, and that gave us a lot of excellent real-world experience to be able to ensure that the clinical trial data was representative. And then there are a whole host of other things. There was discussions that if we got all of our adults vaccinated, there'd be less benefit in children. And then for a while, there was a lot of restrictions on the unvaccinated that now we don't have. So, for example, we don't need to vaccinate children so they can travel typically, because a lot of those restrictions have been removed. And so what I wanted to reflect on, I guess how we came up with this talk was, I guess how did we make this decision to vaccinate our children, and did so on the first day? So I was, of course, very confident with the evidence demonstrating the vaccine was both safe and effective. And, of course, the risk of severe disease is low, but I wanted to do everything that I could to protect my children, and that weighed into it very heavily. And my wife is a paediatric nurse, and while this might not happen often, we agreed on this, and she was also very much on board with getting our children vaccinated. But of course, I involved our children in this process. We've got a 7-year-old and 2 11-year-olds, as you've seen a few pictures of, and some of the comments that came back from them. And, I think they were probably slightly educated on this from having watched me do some commentary around vaccines, but they volunteered that they felt it was the right thing to do. They wanted to protect themselves, and they wanted to protect others around them, grandparents, other kids. And they wanted to get back to doing normal things. They didn't want their sport or their school to be interrupted. And they certainly felt that getting vaccinated was an avenue to potentially do that. So there's obviously a lot of people doing great work, and some have already spoken, and some will be on the call in this space. And you can see there was a forum where I thought that the content was amazing. So, and it's similar to the other groups in terms of the principles, but obviously has to be applied here. So we need clear, consistent messaging. We need the reasons for vaccinating to be consistently discussed. We need people who are familiar to families and children to be in a position to be able to help in this case. And once again, I think, resourcing of general practice is a huge factor there, because some of these discussions take time, and these days, a lot of GPs are very time poor. We need community advocates, but those that know what to say and how to say it. We need lots of good resources. And the next point is about having, making it a positive experience, and show bags and things like that. And there was even some initiatives, I believe, in Melbourne where clinics were at places like the zoo, which I think is a fantastic idea. And then I think even some of the logistics, we know parents are busy these days with multiple sports and other things to do. So just making it really clear when they need to get their children vaccinated, and to get a reminder in a timely manner, and to make it easy to find providers that have the right skills and the right vaccines to be able to give to their children. And so as been said, I got my children vaccinated on the first day, and they were very keen to try and advocate for this. On the left is an article that featured in our paper, the Courier Mail. On the right is something that I posted on Twitter when our kids got vaccinated that had a lot of likes, and I think was largely well received. I've posted some of the positive comments here, and it's always great to get positives back in social media, and I felt very positive about this, and that it was the right decision, and that hopefully the right message was getting out there. But again, as many people on this would know, here are some of the negative responses. It wasn't praise from everybody, and it really surprises me, in fact, how mean people can be, particularly on some platforms like Twitter. And so these are the ones that I didn't actually block or delete. So there were some that were obviously a lot worse than this. And I guess just for context, here's an email I got the other day after being quoted again in our local paper about recommending vaccines for children. This person obviously didn't share my opinions and felt it appropriate to take to email and send me a fairly nasty email about that. So perhaps not everyone agrees, and I guess that's why I think it's really important that we all understand, you know, the role we can play in this. And you know, we've had a great, really done a fantastic job of getting safe and effective vaccine using, you know, a number of platforms. Our uptake in Australia has been really impressive, particularly 2 doses in the general population, but there are a lot of groups that are lagging behind, so there's still work to be done. And so I think it is important that we all play a role in education and advocacy to try and address some of the barriers here in terms of misinformation. And I actually think this is going to get more challenging as we have more vaccine options and our recommendations become more complicated. And I'll leave it there.
Paul, thank you for a tremendous talk. The next talk is about long COVID. What we have worried about in children is it a disease in children? And one of the things, apart from severe disease in children, we worry about is whether they go on to get long COVID. But we're going to talk about long COVID in adults, where most of the experience lies, where most of the problem exists. And a father of the Immunisation Coalition, Associate Professor Lou Irving, has gladly accepted to talk. And without further ado, we all know Lou because he's been chairing meetings and I learned how to chair from him for decades. So thanks, Lou. Over to you to talk about long COVID units and how people are being managed.
Robert, thank you, and good morning, everyone. I should emphasise that although we worry about the acute effects of COVID, there is the group of people who suffer the long effects are also very disadvantaged. And so we need to think of that when we think of the overall effects of COVID infection. And what I'll describe is our experience in the clinic. And the first point to make is that it's not a homogeneous group of people. And there are at least 3 groups of people we see in the clinic. If we just go back to that first slide, there are a group of people who have severe lung damage related to acute COVID. They've been invariably brought into hospital, often intubated. There's a second group who have mild initial COVID, but then persisting symptoms. And then there's a third group in whom COVID actually triggers exacerbations of underlying conditions such as asthma. So as an example of the first group, people who are left with lung scarring, Mr. JR was a patient who in fact wasn't intubated, but certainly spent 5 weeks in hospital and was on continuous nasal CPAP for much of the time and high FiO2, needed to be pulsed with steroids. And even 9 months later, he still has significant lung scarring and is still oxygen dependent, although there has been an improvement in his physiology over that time. Next slide, please. And in this group, in general, the main issues are the pulmonary inflammation, then turning to fibrosis, along with deconditioning, post-ventilation and hospitalisation. These people are at risk of getting secondary bacterial infections. The symptoms that we sort of recognise as long COVID symptoms are less obvious in this group of people, and they respond well to standard rehab for people with lung disease. Next slide, please. In contrast, there's this other group of people, and this case that I'll briefly discuss was the first example we saw back in August 2020, and she was the reason that we actually set up a specific multidisciplinary long COVID clinic. She was a 34-year-old female laboratory scientist living at home with her husband and 2 children. She'd had a fairly uneventful previous history, although had gastritis and short bursts of PAT. Next slide, please. And she developed a relatively mild COVID in July, although you'll note that there was a mild X-ray change. She didn't need to be admitted to hospital, but she was isolated in a hotel for about 14 days, which at the time was an emotional trauma. Next slide, please. On the second and third weeks of her COVID, the initial flu-like illness gradually resolved, but then in weeks 3 and 4, she developed major sleep disturbance, nocturnal palpitations, and she became housebound, mostly, including bedbound, mostly because of fatigue. And she was describing not being able to do anything at all. And this was a marked difference from her pre-COVID status. Next slide, please. She was reviewed by her GP, who was unable to find any physical abnormalities. Screening blood tests were essentially normal. A Holter monitor, because of her palpitations, showed heart rate variability, including episodes of a tachycardia, a sinus tachycardia up to 130 odd, but no specific abnormalities, certainly no evidence of a myocarditis. And the GP commenced her on low-dose Lexapro and sedatives to help with her significant sleep disturbance. Next slide, please. And again, sort of more details about the sleep disturbance and the fatigue. Next slide, please. And she didn't actually respond to the low-dose antidepressants and sedatives, and she was then referred to our respiratory clinic because of breathlessness and palpitations, although her main symptoms were fatigue, this inability to do anything, and her mood had become increasingly abnormal. To the point that she thought she was going to die, and if she didn't die, she was going to develop chronic fatigue syndrome. When we examined her in the clinic, she was in a wheelchair because she was too fatigued to walk. She looked very anxious and tearful, but she was able to do a 6-minute walk test very slowly, but did not desaturate, and her heart rate went to about 115. Her chest X-ray had returned to normal. Next slide, please. So because she was so severely disabled, and because we really couldn't find anything wrong physically on first pass clinical review, we actually admitted her to the hospital, which is an unusual thing these days for people where you can't find severe physical abnormalities. And the reason to admit her was to observe what was happening, to get some further testing, and to arrange for liaison psychiatry to see her. And the outcome of the admission that went for 3 or 4 days was that we didn't find any physical abnormality severe enough to explain her disability. And she had a cardiopulmonary exercise test that was essentially normal, apart from a low VO2 max. She had a sleep study that showed some increased alpha intrusions that are known to occur in non-REM sleep in people with fatigue. And she was reviewed by liaison psychiatry, who highlighted that she was anxious, that she was having panic attacks, and that she was hypervigilant. So we discharged her with a plan of medication to improve her sleep, increased Lexapro to help with her mood change, reassurance, referral to exercise physiology to have a graded activity program, to assist return to work and frequent outpatient support. And to achieve that, we formed the post-COVID clinic. Next slide, please. And the clinic's been running weekly since August 2020. So for 2 years, we see 8 to 12 patients a week, and we resolved that they'd always be seen by the same 2, 3 or 4 respiratory consultants, and that at the end of each clinic, we'd have a discussion of each of the patients by a team that included GPs, liaison psychiatrists, exercise physiology, and other specialists as needed. And this was on a sort of a model of what occurs in general practice for other sort of chronic conditions that require support. And the principles of the clinic were that we would validate the symptoms because they were very real for the patients. We'd use targeted tests to rule out significant physical abnormalities that we could treat. And often we found a sort of screening test at a 6-minute walk, watching the heart rate response and whether or not the patient desaturated was a good physical test. But we often did a Holter monitor or an echo if there were significant cardiac symptoms. And I'll discuss later our use of neurocognitive testing in people with severe brain fog. We resisted a mind-body dichotomy, and the liaison psychiatrist was very useful in keeping us from applying diagnostic labels unless there was a firm physical diagnosis. We spent a lot of time encouraging patients to pace their recovery, and we facilitated a graded return to work. Next slide, please. So in the first 12 months, we saw 102 patients, and interestingly, only 4 of them had actually been admitted to hospital. So they were predominantly that second group of people who had a mild initial COVID and then significant lasting symptoms. And this is probably reflects a referral bias because in June 2020, we had a severe nosocomial outbreak of COVID in our hospital, and we had 250 healthcare workers infected, and many of the patients with persisting symptoms, in fact, were healthcare workers. And their main symptoms were fatigue, brain fog, mood change, breathlessness, etc. Interestingly, about 50% of the patients were able to be discharged once we did a simple screening test, such as a 6-minute walk, and showed that there was no major physical abnormality, and a combination of reassurance and graded return to activity was enough to ensure a rapid improvement. However, the other 50% have required more support, and it's taken longer for them to improve, although everybody has improved. The other thing that's happened over time is that we've now got more of that first group of people discharged with lung scarring. So they now make up about 30%. And it's a sort of an impression that Omicron probably caused more persisting inflammatory lung disease, particularly cryptogenic organising pneumonia, than Delta did. Nonetheless, we've still got a large number of people with persisting symptoms where we can't find a heart or lung explanation for their symptoms. They all improve, however, with graded exercise, with psychological support, And because of that, as well as the clinic, we now actually have an allied health program called Recov that supports these patients. So fatigue, breathlessness, exercise intolerance is common. As I've mentioned, we use a 6-minute walk and lung function screening tests. Occasionally we need to do a CPET to exclude unusual forms of heart and lung disease. Certainly palpitations and autonomic dysfunction are common in this group. The fatigue, we rule out common causes, but the main approach is to support their activity levels and making sure that they don't do more than they're capable of in the recovery period. And psychological symptoms are very common in this group, and not necessarily the cause of the symptoms, but a reaction to slow recovery. So people become frustrated and angry and fearful, and hypervigilance is common, and particularly in the group of people who have significant brain fog. So we've done intensive neurocognitive testing on about 40 patients, and we haven't found any abnormalities in neurocognitive testing, although all of them are hypervigilant, meaning that they detect little abnormalities, little mistakes that we all make day to day, but see them as in fact an abnormality rather than normal, and they become focused on these little lapses. In the last couple of minutes, I'll just present 2 bits of information that have come from overseas. This is the largest and most rigorous view of the risk factors, and it involves over 6,000 community COVID patients who were already involved in pre-COVID longitudinal studies. And they had the usual symptoms of fatigue, breathlessness, and anxiety. And compared to people who didn't get COVID, risk factors for having persisting symptoms were increased weight, female versus male, white ethnicity, poor pre-pandemic physical and mental health, and asthma. And in our experience, particularly poor pre-pandemic physical and mental health do appear to be risk factors. In our clinic, and again, this is probably a selection bias, but we've also noted a subgroup of people who are normally very highly achieving people who validate their wellness by exercising intensely every day. And if they get COVID, some of them are unable to sort of rest and heal. They continue to try and run 20k, for example, a day, and this appears to be a risk factor for persisting symptoms. This is came out last week as a preprint, so it hasn't been peer reviewed. It hasn't been published, but it's a study from Yale looking at immunological differences in a small group of people who are essentially either healthy and uninfected, and a group of people who have been infected and have persisting long COVID symptoms. And what these researchers found were changes in the myeloid and lymphocyte populations in people with persisting symptoms, increased humoral responses to both SARS, but also, interestingly, to EB virus, and a significant reduction in plasma cortisol in the group with persisting symptoms. Now, this is a small study. One of the things that dogs research in long COVID is a lack of a diagnostic test, but these sort of studies might be giving an immune profile for people who have the syndrome, and also give us some insights into possible causes. I think we're at a point where we still don't know exactly what long COVID is, and I just remind everyone about encephalitis lethargica, which is a sort of a mysterious illness that followed the 1918 pandemic, and has never really recurred since. But certainly we need to keep an open mind about what we're dealing with. So it's uncertain times. We need to support our patients. We need to keep an open mind, and we need to be aware that COVID is doing things that we haven't seen with some other viruses. Thank you.
Lou, that was another great talk, comprehensive and insightful. Thank you so much. Our next and final speaker is Associate Professor Michael Murray, who was recently appointed as the geriatric lead to the Victorian Aged Care Response Centre for COVID-19. So he's a good person to talk on this issue of COVID and, to a lesser extent, flu in aged care settings. He's Divisional Medical Director of Continued Care and Head of Geriatric Medicine at Austin Health, and he comes highly recommended, and I'm really looking forward to his talk. Thanks very much, Michael, and over to you.
Thank you very much for the privilege of speaking. I think I've got the easiest task because aged care is so well followed and observed that the data is probably more readily available than most other areas. We're going to quickly cover deaths by jurisdictions, active cases, the vaccination and booster rates, a quick cover on influenza, a bit more difficult in aged care because, as you're aware, the responsibility is shared between the Australian government and state governments, and therefore following the data is quite difficult. And we're just briefly going to talk about therapeutics. If we're looking at deaths in residential care, there's been about 3,742 deaths in total, and it's fairly clear that we thought 220 was bad, but 222 has been much worse. And from a geriatrician perspective, it's quite amazing, and having been involved in VAC, it's quite amazing the focus and the amount of time that was tied up in figuring out exactly when people died and presenting the data on a daily basis. Whereas in 2022, the number of deaths has risen dramatically, but there's much, much less interest and focus. And perhaps that's about information fatigue. This is a current snapshot as of last week. There was 713 active outbreaks in residential aged care, and the definition hasn't changed in terms of resident and staff for an outbreak. As you're aware, there's been significant outbreaks in particularly New South Wales and Victoria, and less so elsewhere. But as a proportion of the total cases, and I take this with a grain of salt because, as people are well aware, we only know what we know, and therefore the testing rate is significantly dropped. But certainly it's a fairly low percentage in most states. Very early on, as people will recall, particularly in Victoria, where we were very hard hit, the number of cases per outbreak could actually become very significant. And those were the days when PP was still rolling out, availability to supply went from disastrously difficult to quite reasonable once the government and the central stockpile got involved, and the government started to deliver within the space of a week or two supplies to all residential aged care facilities. But more recently, it's been a little more challenging to get supplies, or certainly from a facility point of view. And there's certainly concern from facilities when not in outbreak around the cost of supplies, and this has become a major issue in residential care. But what we noticed early on is that a number of the cases were relatively large. Later on, and in other jurisdictions, the case numbers were actually much smaller, but the case numbers seem to be slowly rising, which is a little bit counterintuitive in some senses, because we seem to, in general terms, get much better with PPE. It's interesting, I'm not sure what other people think, but certainly we spent a lot of time as part of the prevention team early on, sending support services, sending people to audit and to educate locally to residential care. And what we found was that although there was a general trend that good facilities stayed good and facilities that struggled continued to struggle, because there was significant staffing turnover, it was actually quite difficult to get carryover of both education and practice. That wasn't universally true, but it was certainly definitely seen. And there was obviously great benefit, or we certainly felt there was great benefit through the work of the armed forces going out and doing on-site education and audit. As people are aware, the turnover in residential care in terms of staff, and this has been a major problem with training, has been up to 24%. And when you've got turnover of up to 24%, less in some areas and higher in others, that is nurses versus personal care attendants, it's very hard to not only to get the culture of the organisation embedded, but it's also hard to educate practice and procedures. And a turnover rate within hospitals where we get new rotations periodically of residents and registrars, we struggle with that, and it's nothing like 24% turnover. In terms of vaccination rollout, we've become very focused on the winter dose, and in general terms, whilst Paul's been absolutely correct that the first two doses were highly successful, there was what's been so-called vaccine fatigue with subsequent doses. I don't quite fully appreciate or understand vaccine fatigue. I think it's still around messaging, and certainly our experience has been both in the facilities, of which there's about 15 that I'm on the boards of or directly related to attending as a clinician, where it's really around messaging for the most part, not entirely for the most part, and certainly it's not so much the message, it's the messenger. So when we've been able to secure, particularly in coal communities, colleagues who are well regarded within that community, and they proactively advocate on the behalf of vaccination, there's been a marked uptick. It's also fairly clear that the facilities that have fewer GPs or that are well engaged seem to get much better outcomes. And certainly I've noticed in the facilities that I'm in, it's either a few doctor facilities where you've got good engagement, or strong central engagement through the leadership team at the residential care facility, which seems to make a difference. But interestingly, about 80% of those people who are eligible to receive the fourth dose have in fact received the fourth dose, and that's significantly better than the community average, which is 71%. Interestingly, when we look at why those people haven't been fourth dosed, the majority, that is 70%, are related to a facility outbreak. Now, that's not only the fact that people have had antivirals and therefore we delay their vaccination, but because vaccination is managed largely, although not entirely, through the Commonwealth Department, those facilities that have had an outbreak tend to get put back down the list, and therefore it's a resource utilisation issue. As you're aware, some facilities, particularly the bigger groups, are managing vaccinations on their own recognizance, and they're actually doing quite well. So in general terms, it's the 80% doesn't look as good as we'd like, but when you look at why they're not vaccinated, it's not nearly as bad. If you pull out the data for our Indigenous population, not across, not the over 65s, but those in residential care, although it is a few percent less than the national, it's actually surprisingly good and certainly much better than the Indigenous over 65-year-old population that Paul presented. So we are having better impact in residential care. If we're looking at deaths and in residential care, and we're looking at COVID deaths as a percentage of the whole, there's been some discussion as to, and this is particularly relevant to the efficacy of the vaccination or vaccines and the roles of in-reach services, general practitioners, etc. It's been very difficult as a clinician, as a geriatrician, to figure out how many people died with COVID or because of COVID. And understandably, in residential care, particularly in more recent times, and I mean recent years, not just overnight, populations entering residential care have become significantly more frail. And regardless of what frail measures you use, whether we probably most commonly use for ease the Rockwood-based model, it's pretty evident that people have been able to delay entry to residential care, both because of alternate options in community available, which has really been a government initiative over some years, but also because there's been increased reluctance more than any time before to go into residential care. Now, I'm not saying that people look forward to going to residential care or even necessarily embrace it positively, but it's certainly true that there's significantly more resistance. And as information around places like St Basil's and the coroner's review of St Basil's becomes more evident or well publicised, there's probably a bit more resistance, particularly where I work in the north of Melbourne at Austin Health, where St Basil's is considered relatively local, and other residential care facilities that were particularly adversely affected by COVID, such as Epping Gardens, also plays in sort of the public perception of the role and safety of residential care. It's a sort of a long discussion point as to how you actually analyse the direct effects of COVID. And it's particularly relevant because when trying to look at the benefits of vaccination and the benefits of antivirals, both of those become particularly important, and I'll discuss that in a moment later. Influenza vaccination is much more difficult to get a handle on for the most part because the data is much less readily available, unlike COVID, where the information is required to be submitted to the department. Influenza vaccination, whilst the data is required by the department, it's not required at the same interval as is COVID. So there's really a mix of national and state legislation and regulations. And as people are well aware, one of the things that's continually tripped us up from the start of COVID has been this jurisdictional challenges between state and Australian government. And regardless of your political views, few would think this is really long-term a good plan. I can understand why people are fairly reluctant, and I know I spoke to the minister prior to COVID, who told me there was no political appetite to fix it. And understandably, one of the big problems is it's particularly in older populations is that you'd need an open checkbook, and nobody wishes to take on that responsibility. But certainly it's been a major stumbling block and continues to be a major stumbling block, and I have little doubt it will continue to be so for my entire career. That is, we know that one group looking after health makes great sense, but that's simply not going to happen. As people are aware, one of the things we did from a government perspective, much as the same way we did with antivirals, is ensured that there was pre-deployment to residential aged care. When we were approaching flu season, we turned our minds to flu season. From an advisory group perspective, we and probably others were very concerned that we could have a particularly bad flu season. We really had no idea, but it seemed to be quite a reasonable concern, given that we had effectively had almost no flu or, in fact, any significant respiratory disease, viral disease for some years. We were, in a sense, preparing ourselves for significant outbreaks. As you're aware, that hasn't really occurred, but it's not unreasonable to think so. But one of the things we then did was to actually pre-deploy Tamiflu. In terms of requirements for reporting, this is actually predominantly under the Aged Care Quality and Safety Commission, who assess compliance. And really, the compliance is not around your vaccination rate. It's really around how you've promoted, informed and encouraged influenza vaccination. We've certainly noticed, and I'm sure you've clinically noticed as well, there's been a significant reduction since July, and the data shows that, which I'll show in a moment. And certainly that's evident in the notifications. So for those of us who look at the Australian Influenza Surveillance Report, and this is the report number 10 from the 14th of August, because they have pretty graphs, it's pretty evident that there's been a marked drop-off. If you look at the red, there's been a marked drop-off in flu cases. And if you look at the graph to the right, figure 5, it's evident that this drop-off is not related to testing. We're still testing significant numbers of people. However, the flu rates have dropped quite dramatically, which is obviously good for all of us. We're certainly still seeing plenty of RSV and metapneumovirus, probably to a much lesser extent, but we're seeing relatively little flu. Okay, sorry, I was just going to mention the work done by the Doherty Institute. So, not in any way wishing to steal their thunder. They're currently looking at the clinical outcomes from in residential aged care, analysing the data, and to try to demonstrate or trying to ascertain the efficacy of the vaccination program and the benefits of antivirals. We're awaiting a final report, but I think from a clinician's point of view, what we're likely to see is that it's probably part what you do, i.e. vaccinations, a significant part of the underlying health of the individual concerned, and the role of antivirals seems to be better than I anticipated in terms of efficacy. Thank you.
Michael, thank you so much for another highly informative and up-to-the-minute talk on aged care facilities. And thank you so much for keeping to time as well. Great talk. We've got a bunch of questions which I've been writing down and sorting through. As Michael's just spoken, I might keep him on screen and ask him a couple of questions that have come through for him. When fourth doses are given, they sometimes are delayed, as you said, by having a local outbreak. What is the gap between having a local outbreak before you recommend giving a fourth dose? Is it a month or 2 months or longer?
Just making sure. I think we're all recognising that the longer period of time that we recommended is now becoming progressively shorter. And one of the things that actually delays us is not the timeline, which we're looking at a month, but in fact the ability to deliver the vaccinations to facilities. There's 2,700 odd facilities across Australia, and the logistics of actually getting people out there is particularly difficult. When you think about the fact that between 20 and 25% of people pass away in residential care every 6 months, the problem is it's not a static group, and the turnover of staff and the turnover of residents is very significant, and therefore it's you're fighting it's a perpetual challenge to get teams out to do the vaccination. As you're aware, some of the larger providers are doing their own vaccination, And some of our GP practices, particularly the group aged care GPs, are doing some of the vaccination. But where you've got to get out somebody from one of the government service providers, the logistics is probably one of our biggest challenges. So in general terms, we try to get it within the month, which is why we use the 30 days in terms of our data.
Great, that's clear. Thanks, Michael. One more question to you. You talked about jurisdictional friction. Can you drill down on what or remind us what you said, what the one or two key facts were? I was certainly familiar with the Commonwealth Government trying to do their best to support aged care vaccination and some efforts through the office of General J.J. Fruin. But what could you just drill down and remind us what the key issues there were?
And keep my job. Yes. COVID's been blamed for lots of things, but I can remember being in a paediatric short stay bed, having collapsed at work, and we were unable to find a bed for me, the medical director, within my own health service. And my wife took me to another hospital where my cancer was diagnosed and I subsequently had surgery. Things were terrible before COVID. Maybe terrible is an overstatement, but certainly they were particularly challenging pre-COVID, and things got much worse. I think that we're always recognised that we could have a pandemic, and I remember there was a particularly interesting article on novel coronaviruses and pandemics a few years prior to the pandemic occurring. But when push came to shove, we found out how little prepared we actually really were. And there were a whole lot of services and teams from public health that were basically tripping over each other. And the figuring out who was in charge of what was particularly problematic. Certainly, both governments worked very hard to try and get things into some degree of order over a very short period of time. But because the responsibilities for who was responsible for what, it was particularly difficult. Now, in aged care, to some extent, it was a bit easier because aged care is an Australian government responsibility. And to that end, it was much easier to get things like PPE, etc., out. But getting the relationship between residential care and public health at a time when we actually hadn't gone to a spoke and hub model or a hub and spoke model, it was quite difficult, and a lot of work had to be done to play catch up. I think fundamentally where you've got the possibility of cost shifting, real or inadvertent, or where you've got systems that are set up that across jurisdictions, it makes it particularly difficult. So, for instance, the in-reach services, of which I run a substantial one in the north of Melbourne, our funding runs out in the 30th of December. Now, at that point in time, I go back to 3 sessions of medicine, which is dramatically less than, we're up to 20 or more staff, nurses, etc. So this is the reality as you trip over yourself whilst you're trying to develop services. And I'm sure all my colleagues have been challenged by running short-term funding in a system that is already overwhelmed. And I think you could probably have a whole session on this, but fundamentally, that's the problem. And I don't think we've got to the point where there's any particular government who wants to take overall coordination for this.
Okay, thanks, Michael. I may come back to you if we have time with other questions. Paul, the question has been posed to you. Well, there have been many questions posed. One is about Moderna vaccine. Is it ready-made? I don't know if you want to talk about that. I know that there's 10 doses per vial, and the new one for children under 5 and under is a blue cap. Do you want to add anything to that one quickly? We'll have some quick fire questions. Go ahead.
No, I think that sums it up well enough. And of course, the next thing we're going to see with these vaccines is the Omicron specific boosters that we should have available in our country towards the end of the year. But that's about it.
Yeah, I'd agree with you that the Omicron boosters may well be very helpful. Gary Groman has asked the question, Wouldn't they be better? And you've answered it by saying they're not available yet. And we have no knowledge to predict the future that the new variant might be just around the corner. But we do know that the data suggests that ancestral strain vaccines continue to protect against severe disease. Do you agree with that?
Yeah, absolutely. And of course, one of the big strengths of those new boosters is they're going to be bivalent in the first instance, which has some benefit in terms of, boosting that protection from severe disease with the original strain and maybe getting better cross protection from the Omicron components. So, this will be our first step forward in improved vaccines. And I think I'm actually touching on this a bit in my talk this afternoon. So we might come back to it then.
Okay. Well, Angela Newbold has asked for you to re-emphasize the key points regarding talking to parents about the importance of COVID vaccine for young children. Have you got, what are your clinching arguments?
Look, I think it can be difficult, and the main thing is to understand what the parents' concerns are and what their needs are in terms of information, and being able to give them an explanation that works for them. Different parents have different past experiences, different concerns, different understanding of how the vaccines work. So you do need to take some time and go through those things, and that's where resourcing in the general practice land and in pharmacies is so important. But as I say, it's just about making sure you understand where they're coming from and can explain it to them so that they can make an informed decision.
Several people have been asking about, the confusion and the conflict around whether children should be vaccinated, and they harked to my suggestion a year ago that we should be cautious and limit it to high-risk kids. But then the epidemiology has changed, and I've just seen data from the US where 3 different waves of Omicron have happened this year, all causing more deaths than flu does in any one year. And increasingly more with Omicron affecting so many children. So it seems to me that the issue keeps changing. But I was asked to say, well, why was I against vaccination? Well, a year ago, we were concerned that vaccination of children would cause myocarditis the way it did in older teenagers. So that was one concern. As one questioner has said, we don't know the long-term side effects of vaccines, and so we have to be somewhat cautious about recommending something that's got an immediate benefit, but we don't know its long-term safety. We know about millions of children who've been vaccinated for months now, so we've got some good early data. And of course, a year ago, most cases, virtually all cases, seemed to be mild in children, and even with the Delta wave in the second half of last year, only 1 in 100 children reviewed were hospitalised, and 2/3 of them were for social conditions. Okay, Lou, 2 questions. Why do you think your patients are reporting so much hypervigilance? So that's a theoretical question, and a more practical question. What do you think the vaccine effectiveness is of against long COVID, and do any of the antivirals help or prevent long COVID? 3 questions.
So I think our initial thoughts about the hypervigilance were, we live in existential uncertain times, and that, possibly it was a manifestation of just widespread anxiety, throughout the community. But what hasn't been excluded is the possibility, that the virus is actually having direct effects, rather than secondary effects on people's sensorium, the way they perceive things. And hypervigilance when it comes to noting everyday errors in memory is very similar to unexplained breathlessness, where some people become more aware of the sensation of breathing. And it can also apply to palpitations, it can apply to pain syndromes. But whether the cause of the hyperperception is external or internal, we just don't know. Regarding whether vaccination protects against the possibility of getting long COVID. I mean, we're talking about 5%, that study from the UK, of people getting significant persisting symptoms, and then about 15% of people getting relatively minor symptoms that persist more than 3 or so months. There was an initial paper suggesting that vaccination might protect. However, the more experience we have is it doesn't appear to be protecting. And most of our new patients in the long COVID clinic have been vaccinated.
Thanks, Lou. A couple of questions for Paul. Do you think we're reaching a point where boosters may only be needed every 6 months, maybe every 12 months? And while I'm posing questions to you, what about people who've had 2 and even 3 COVID infections? Do they actually need any extra vaccination?
I think it's been said a few times, it's impossible to predict the future. And, while I think at this stage we'd say that, boosters are going to be required and a 6-monthly interval would look like it might fit the bill pretty well, but that's going to be a huge demand moving forward to do that twice a year. And so there may be some logistical and pragmatic reasons why we don't go that frequently. And the other thing, and again, I'll touch on this later this afternoon, is we're going to have combined vaccines hopefully soon too, with flu and COVID and maybe RSV. And so there might be an opportunity to go to an annual booster that gives protection against multiple different things. So, and it also depends on the new variant. I mean, as this virus has shown us, it's unpredictable. We could have a new variant next week. That means we need to change our boosting strategy and adapt again. So I think that the only thing that's clear is we're not going to get lifelong protection from the vaccines we've had so far, despite how effective they've been. And so boosters will be required, but the interval and what they're composed of, I think, is impossible to predict. And in terms of boosting after multiple infections, again, we know people get some protection from infection and that perhaps hybrid immunity is the ideal, but once again, that's not going to be lifelong and the virus will change as well. So future boosters will be required no matter how many infections you've also had thrown in.
Yes, I'd agree with that. And I'd also make the point that if you had 2 or 3 COVID infections, there may be a question about your immune system, not just your immunity to COVID. So it may be a reason to vaccinate more rather than less, or at least to vaccinate rather than not. Lou, one of my questions, I threw too many at you, was about whether antivirals or any drug are helpful for long COVID.
We don't know is the short answer. Yeah.
Fair enough. I've been studying the literature for the last 6 or 9 months about RCTs and studies in the UK, and they're not reporting results, which suggests that they're not getting much benefit. Drugs like blood thinners, or what's it called, apixaban has been touted, but there's no data, as you say. Michael, coming back to you, I was intrigued by your data of death, and there seemed only to be under 200 deaths in 2021 in aged care facilities, less than 200 it seems. I thought you'd had more than that alone in Victoria in 2021, but educate me. You also show close to 3,000 deaths in aged care facilities in 2022. So could you just compare and contrast on those numbers for us?
Yeah, I suspect I may have transcribed the numbers. I was trying to be a bit too smart, which is probably never a good idea for a geriatrician. A bit too smart with combining 2 graphs, and I think I may have actually transposed the numbers. So I will go back and I will send you the right numbers, because we're looking at it, to me, it looked far too favourable, quite frankly. So I think the total numbers definitely correct, but I think the distribution. One of the problems is the government keeps on giving data over different time periods. And November is a sort of a period when we changed the way we collected some of the data. So it's often done till the 29th of November. So I have a feeling that the data I've given you might have been transposed, so I'll send the correct data. But the total number of deaths at around 3,700 for the total pandemic is about right. And depends on where you are. Victoria had certainly more deaths at the start, but of course, every death was well documented. Now every death is pretty much ignored.
Yes, thanks, Michael. Someone called Vicky from Victoria, aptly, made the very important point that local government LGAs have capacity and experience in their nursing vaccination workforce, and they were not as well used as they could be. Michael or Paul, would you like to comment on that?
Look, I think there are lots of things that we could have done better, and I just hope that we do look at those sorts of things, look at where the resources are that were perhaps underutilized or not used optimally, and try and make sure we don't make some of those same mistakes moving forward. I think there's lots of learnings we can take away from some of those types of experiences. Yeah,
thanks, Paul. And we do need to make good use of all our highly trained expert colleagues in medicine, pharmacy and nursing, etc. I've got a question. I'm going to wrap this up shortly, but I've got a question about maternal antibodies. Do they cross the placenta? And that's an easy one to answer by me, yes. And do they protect? I did show one slide which has looked at the protection in the real world, in the field, of mothers being vaccinated against COVID, and the curious observation, which, well, not really curious but interesting, was that there was nearly 80% protection in infants of mothers vaccinated if they were exposed to pre-Omicron strain like Delta, where there was only 40% protection in children of vaccinated mothers for Omicron. Showing again that the vaccine is mutating and changing. If you drill down on that data, the protection is higher if the mother is vaccinated after 20 weeks rather than before. I'd just like to throw it open for 1 minute to my co-speakers if anyone feels that there's a key point that they haven't been able to get across or that they want to emphasise before we close the session.
Robert, I've actually got a question of Michael. During the most recent wave, when I was working clinically on the COVID wards, I was sort of impressed by the amount of inanition, just not getting out of bed in some of the very elderly patients who were acutely COVID positive. So they didn't have a pneumonitis, they didn't have renal failure, they didn't have heart failure. Their inflammatory markers were relatively normal, but they literally just languished in bed. And my question is, had he seen similar cases? And the second part of the question is, does that occur, with other viral illnesses in elderly people?
So for the second bit first, the answer is yes. And the first bit is in fact a bit complicated. I'm embarrassed looking back and wondered how much better we could have done. But at the time, we were incredibly anxious, paranoid, concerned, and the general plan for management of all people with COVID was keep them in their room and don't go near them. And I can tell you that's a really good way for very older people who are incredibly frail to do badly. And, one of the key factors, within the definition is undernutrition, and undernutrition is a huge issue. It's hard to me as a fatter older man who just thinks about food and puts on weight to when I comprehend some of my older patients who nutrition is an incredible struggle. Just getting nutrition into people when they are feeling fatigued in any illness, particularly significant illness, infection, virus, whatever, is a real challenge. And I think that's something that we underplay. Certainly, we've done lots of work around PJ paralysis, trying to get people out of bed, but I think we contributed to it. I think we left people in rooms. Residential care was a bit of a disaster in terms of lack of staffing, and people's nutrition was terribly underdone, let alone their hydration and everything else. And some of it's come out in the coroner's report, but probably you ain't seen half of what in fact really happened. So yes, I think you're absolutely correct. I think looking after people's such basic things as nutrition and mobilising, getting them out of bed, sitting out of bed, even from a lung point of view, is absolutely critical. And it's not something we did. We could have done better mentally or philosophically, but we didn't also have the staff either. So, you know, we sort of did as best as we could and we thought was appropriate, but in retrospect, maybe it wasn't quite as good as it should have been.
I think that's an important point on which to close. A lot of great talks this morning. So thank you to all the speakers. Thanks, guys. Great session. Thanks for all your presentations and answers. Thank you.